It's a pleasure to be here. As you know, I'm interested in memory and Alzheimer's disease, and we're going to talk today about some of uh, my my work in this area, and I hope that I can give you a little bit of a new take on how you think about memory and how you think about early diagnosis of Alzheimer's disease. So, so the first thing is memory isn't one thing. Okay, memory for what? Memory for new material, memory for objects, memory for riding a bicycle. These are all different kinds of memory, and they're supported differently in the brain, but they all work together very seamlessly. And it's all just a seamless whole when things are running normally. Okay, what happens when things aren't running normally? That's what we're here to talk about. So I'm going to outline my talk this way. I got into this field because I was really interested in how the brain works, the organization of the brain. So I'm going to start there with a few slides. And then we'll talk about how that relates to Alzheimer's disease, because it turns out Alzheimer's disease respects the functional organization of the brain. And then we'll talk about how we use that knowledge to understand Alzheimer's disease better. Not just from the perspective of what's lost, but also what is retained, because that's important for approaching patients. And then finally, I'll spend a few minutes at the end talking about the kind of state of the art and how we're treating Alzheimer's disease. Okay, so brain organization and memory. So the brain has an architecture. You experience it all of a piece, but actually the brain is a machine. It's got an architecture, and that determines how it works and how it can break down. Okay, just like your car. I have a pointer here. Your car won't start. There's a differential diagnosis of what's the matter with that car, right? When it's not working. And it's the same thing with the brain. That's what a neurologist does, is analyze what is the pattern of impairment, infer where in the machine the problem must be, and then what we can do about it. So let's talk a little bit about the brain. I'm an imaging guy. I always have to remind myself the brain is an organ with blood vessels and membranes and things like that, because I usually see something like that, like the black and white image. And the brain is organized into pieces that we talk about: frontal lobe, parietal lobe. We'll talk a lot today about the temporal lobe of the brain, which is this part, because this is the sort of memory lobe for the brain. And then if you take that brain and you cut it this way, you see something looks like that. And you can see the brain has got the core of what's called white matter. It's white on this image. And then it's got this outer rind of gray matter, which conveniently is gray in this image. And thinking and memory happens in that gray matter layer, the cerebral cortex. And it looks kind of thin, but if you roll that all up, that's fully half that volume of the brain is contained in that gray matter outer rind of the brain. And information is the stuff of cognition. Cognition is the collective process of obtaining, storing, retrieving, transforming information. And it happens in that cerebral cortex I just showed you. And it's interesting. It happens not in terms of binary ones and zeros. It happens in terms of the elementary sensory percepts that you have. That's an interesting part of the functional organization of the brain. And I'm going to just try to explain that real fast. But that's what the brain kind of looks like from the side and from the middle view. If you split it down the middle, that's what the middle looks like. And all these areas that are colored blue are areas that are directly connected to your senses or to your muscles. Okay, so this blue part here in the back of the brain, that's your visual cortex. That's where the fibers coming from the visual system come into the cortex. And this area here along the center part of the brain, that's your somatosensory cortex. That's where senses of touch are relaying in directly into the brain. And then you also have other senses, like internal to your body, right? You have stuff that senses what's happening inside your viscera and so forth. And that shows up in these really core areas that are colored red here. Those are the only ways that information gets in or out of the brain. It's through those portals that are connected to the sensation external to you or internal to you. Everything else is processing information in between that. I can explain to you what I mean by that in a second. Oh, that picture there in the lower left, you don't know who that is. And if somebody doesn't know who that is, I'll be amazed. It's a guy named Frank Conroy. He used to lead the Iowa Writers Workshop. I was in Iowa for many years. And he said that when you give a talk, it's like asking your audience to climb up a mountain with you. Everything you tell them, they better need, because they're going to have to carry it all the way up the hill. So he's sort of my muse here. I'm telling you all this information, but take my word for it. You need it to understand my talk. All right. So then I told you the brain is organized around these sensory portals, sensory and motor portals. And for example, this part of the brain is connected to the motor system and that part to touch. And that turns out to be a major fissure in the brain and a major dividing point between what we call the sensory brain, which is everything back here that's concerned with elaborations of vision, hearing, and touch, and the motor or action brain, which is everything in front of that, which is connected with motion, but also the abstraction of motion, reasoning, and manipulation of information. Okay. And it's interesting how this really works, because here we have touch, hearing, and vision. And if you damage those parts of the brain, you'll have trouble that's limited to touch, hearing, or vision. But as soon as you start to get outside that, like into these green regions, you start to get sort of more elaborate problems with vision or hearing. Like you might only have trouble seeing color. You might only have trouble seeing motion. And then you get farther out into these areas that are yellow. Then you start to integrate across these channels. And that's how you get to your ideas about space. Space, three-dimensional space, is an abstraction of vision and touch. That's what it is in the brain. Or words are an abstraction of hearing and vision. They have a form, a visual form, and they have a sound, and they have a visual concept that they correspond to. So that's kind of how the brain is organized functionally radically around your sensory systems. Okay? And the farther forward you move in this temporal lobe, the more elaborate that aspect of knowledge that is encoded in that region. And your concepts, like your idea about who I am, or what a rhinoceros is, or some concrete entity, is supported in this very anterior temporal lobe. So semantic knowledge is an abstraction of the sensory brain, or abstraction of sensation. And it's a different kind of memory. There's my muse. He's happy with me. And then the action brain, like I said, this is what underlies reasoning and acting appropriate to some particular context. And the farther you go forward into this yellow area, the more nuanced the context that is processed there. So like behaving appropriately in a social situation like the one we're in right now, that's a high level job for the brain. That's relying on your prefrontal cortex. That all makes sense to people? That's kind of my racing view through the organization of the brain. So you can see that because of the way the brain is organized, cognition splits into these natural domains, things like spatial cognition or language, executive functioning, and these domains correspond to certain regions in the brain. And that's what the mechanic, the neurologist, is analyzing when we're looking at patterns of symptoms and trying to figure out where in the brain the problem must be. So now let's talk about how memory breaks down. So I told you there's different flavors of memory. So immediate memory, or what is properly called short-term memory, is what you can maintain in consciousness continuously, okay? Like rehearsing a phone number, 592-8362. That's my neighbor's phone number when I grew up in Ohio. But how many numbers can you keep in your mind as you go across the room to dial the telephone. That's about 7 items on average for people, and that's why phone numbers are 7 numbers long. But that's immediate or short-term memory. Working memory is the same sort of deal, except that you're doing some sort of manipulation on the contents. Like, remember the number, and when you get to the other end of the room, write it down backwards from the end to the board. And that's a working memory problem. But it's all right there in the tabletop of your mind the whole time. And as soon as as soon as it gets out of consciousness and you need to pull it back into consciousness. So, I'm walking across the room, someone calls me from the other room, I answer them, and now I'm back to remember the phone number. Now I'm already in long-term memory. Okay. It's departed from consciousness. I need to reconstruct it in my consciousness. And now it depends on a different brain system to do that. So that's different between short-term and long-term memory. And the way this works in the brain for long-term memory is it got all these parts of the brain that are sending their connections, all choking through this area that I've got marked with the red square there. And if I now cut the brain here, where's my pointer? Cut the brain the other way, like this way, and look through that red square, I see this. And you see this kind of curled up edge of the temporal lobe. Can anybody see that maybe looks a little bit like a seahorse? Okay. The seahorse, that's called the hippocampus, which is Greek for seahorse. And that is like the magic structure for memory in the brain. All this information is coming through and choking through this point called the entorhinal cortex. And by the way this architecture works, this entorhinal cortex here sends all these fibers into this memory structure called the hippocampus. And this turns out to be the choke point for memory. All you have to do is damage this little tiny brain area and you will become unable to remember new information. So turns out that's early vulnerable in Alzheimer's disease. That's why we're talking about it. We didn't used to know that. The way we discovered that this part of the brain is so vulnerable, I'm going to skip this part, was in 1952. There's a very famous patient in neurology. His initials are HM. We actually know his name was Henry. He was someone who had brain trauma when he was a child and had a lot of seizures as a result. And there was a doctor who said, I can do this innovative operation. I will take out his hippocampus on both sides and cure him of his seizures, which he did, cure him of his seizures, except after that happened, Henry could not remember any new information. So you would leave the room, come back, and he would meet you again for the first time. Okay, one of the most profoundly amnestic people on the planet. Okay. And then we realized, I think there was another operation. I mean, it took a couple patients for them to track this down. But this, holy cow, the hippocampus is crucial for memory. We have to stop doing this procedure. So that's how we kind of tumbled to the idea that this part of the brain is so crucial for memory. And I'm going to just tell a little aside at this point, because despite his profound amnesia, HM was able to learn things. So the kind of things he could learn was like riding a bicycle or anything you would learn by rote, any skill or procedure that you would learn by dint of repetition. Even though he would not remember having done it, he wouldn't remember having ridden the bicycle, but he could walk up to the bike and get on it and go. Or a good, better example is, how many people have played Wii bowling? Yeah, you remember the Wii? Okay, yeah, it's like he could learn to play Wii bowling. Okay, even though the technology was not invented anywhere near the time when he had this brain damage. And this procedural memory or implicit memory is a function of other parts of the brain that weren't damaged in his epilepsy surgery, and which, as we'll see, are also spared in Alzheimer's disease. So people with Alzheimer's disease are able to do these sorts of implicit or procedural learning tasks as well as anybody. All right, so that's the first part, talk about brain organization and basic things about memory. So what about pathological memory or memory loss? So to talk about that, we need to talk about what's normal for cognitive aging. All right, so because we do have a little trouble with memory as we get older. I think the most common thing people notice is they have sometimes trouble pulling out a particular word for something, right? Somebody's name, something that you use every day. What's the name of that? Right? How many people have experienced this? As far as I can tell, about age 35, this starts to happen. It's not enough to interfere with your communication. You go to remember it next time and it comes to you like snappy. It might even bubble up on its own in the meantime because you've sort of primed it. But that's a normal aspect of cognitive aging. Everybody gets a little slower at thinking. Everybody gets a little less flexible. It's a little harder to change tack. And everybody worries about their memory a little bit. That's normal, okay? And then there are other aspects of cognitive aging which are on the good side, like this idea about having things departed from consciousness and then needing to bring them back as long-term memory. That should be intact as you age. Okay, that's typically normal. You tend to get wiser. You tend to understand what other people are thinking better as you get older. You're able to you speak more slowly, but you speak more efficiently, and you convey your point more effectively as you get older. So that's normal cognitive aging. And like I say, it's normal to be sort of concerned, but at some point, people who are developing memory loss sort of cross a frontier where objectively compared to your peer group, you're having trouble with memory, right? And so we are currently calling that sort of mild objective loss of memory as mild cognitive impairment, or MCI. Have people heard the term MCI? Hopefully you're hearing this more and more, because this is when we want you to come to the doctor. This is when we can do the most for you. And it's a state of objective mild impairment, but you're still independent. You're your own decision maker. You're just fine living on your own. You may be still working. Okay. And at some point, if memory loss becomes more important, you start to become more dependent on other people for things. Keep track of your money, keep track of your medicine, whatever other sort of instrumental activity of daily living you might be having trouble with. And as that starts to become a problem, then we start to use the term dementia. Dementia means objective impairment plus dependency. Okay, and we have ways of measuring that. That all makes sense. And so when we think about sort of trouble with memory, we think on two levels. We think on the first level, when I just showed you, what's the matter with memory and thinking? What's the matter with the mind, if you will? And then the second level is, okay, so what's the matter with the brain to explain what's the matter with the mind? What would you see if you could look under the microscope? That's the deeper level of diagnosis. And that's where Alzheimer's disease comes in. The term mild cognitive impairment or dementia means sort of a syndromic level or cognitive level of diagnosis, but there's a deeper level of diagnosis, which is biological or causal. What's the matter with the biology? And that's what Dr. Alzheimer saw in 1906, I think it was, when he studied the first patient who's under the microscope. Her brain tissue looked like this. And what you see here are the two characteristic problems in the Alzheimer brain. One is these large circular plaques, amyloid plaques. So we say amyloid plaques because they're made of a protein called amyloid protein. They're outside the nerve cells. They don't belong there. They only happen in Alzheimer's disease. And you can even get a sense, like, look at this plaque. There's something going on the edges of it. You actually have some inflammation. You have some dying back of the nerve processes, almost like, Wicked Witch of the West's feet kind of dying back under the house sort of thing. So there's some reaction because this is in some sense toxic to the brain. And then you see also in this microscopic view, you see these little flame-shaped dark things. Those are called neurofibrillary tangles. Those are inside nerve cells, and those are made of a different protein called tau. And those show you the cells that are sick and dying from Alzheimer's disease. Plaques, sort of the insult, and tangles sort of tracing the impact of Alzheimer's disease. And there's my friend, the hippocampus and entorhinal cortex. And under the microscope, all these little white things are neurofibrillary tangles in the cells, the very cells that are connecting the entorhinal cortex to the hippocampus. And this is the first thing that goes wrong in Alzheimer's disease. It's a laser-guided hit on memory, on the choke point of memory. And that's why people with Alzheimer's disease have memory trouble. Took us a lot of years to figure that out. But that Alzheimer's disease does not affect the brain evenly. It affects certain parts strongly and early, and this is ground zero right here. And so, the memory trouble is due to involvement of the hippocampus and its immediate connections. And that's why prodromal Alzheimer's or mild cognitive impairment due to Alzheimer's is characterized by trouble retaining new information. And we use the term amnestic mild cognitive impairment or amnestic dementia, which in the past we would have called dementia of the Alzheimer type to describe that. And then the blue areas, the areas I talked about earlier that were directly connected to sensation or motor function, those areas are not affected. And in some people with Alzheimer's disease, they're never affected. They're spared. And that explains why people who are getting Alzheimer's disease, you can't tell from the way they walk or talk or experience the moment. You can go to a party with them and have no idea how much trouble they're having because motorically they're perfect. So this idea of a big hit on long-term memory and a total sparing of elementary neurological function is what we expect to see in somebody with Alzheimer's disease. Okay, so then just to pull it back, so memory in Alzheimer's disease shows a spectrum of impact. Episodic memory, the long-term memory, is the most impaired. That's due to trouble in the hippocampus. The semantic memory and the working memory that I talked about earlier that involve manipulating or sort of higher aspects of information, they're also affected, not as badly, but they are characteristically affected. Your immediate memory, the ability to rehearse that phone number, is not so affected. And then your procedural or implicit memory, to learn a new habit or skill, that's not affected. So Alzheimer's differentially affects these parts of memory. Okay, so now if you have amnestic mild cognitive impairment, let's say you come into my office and I evaluate you, and yes, unfortunately, there's an objective impairment, and we ended up calling it MCI. What does that mean? What's your prognosis? If we don't know anything else about you except that this is sort of developed insidiously, still, there's about a 10% chance per year that you would worsen to the point that we would say that's dementia next year, and 10% more the next year, and then 10 more, and up until about 70% chance. So about 75% of people with MCI will go on to develop dementia, almost always Alzheimer type dementia. So if you have MCI, we're worried that might be what's going on. We'll talk a little bit later about what some of these other things mean, but there are some other things we look at, like, do you have more going on than just memory? Do you carry this particular genetic marker? Or do you have an amyloid biomarker, which is the latest thing? Then we know your chances of going on to dementia are much higher. And that's when we try to intervene with medicine. Okay, so the Alzheimer's manifests with this amyloid protein accumulation in the brain, and then these neurofibrillary tangles begin to form, and they begin in that medial temporal lobe where the hippocampus is, and they spread throughout the brain over sort of successively more severe stages of the disease. And we now sort of can map those stages onto what we see at the sort of cognitive or syndrome level. And we've talked about dementia and mild cognitive impairment. And it turns out before that phase, it was 15 years when you can find neurofibrillary tangles in the hippocampus and nearby places, sparsely, and your memory is normal. Okay, 15 years of latent disease process that we can detect. You'll hear we can detect it and know that eventually something's going to go wrong. Right? Is that good news or bad news? I think it's good news because it means there's 15 years when we could theoretically intervene. If we could slow it down, the way the math works out, if you could slow it down by just 5 out of those 15 years, you would cut dementia in half. That's the way the math works out. So that's where our attention is in that pre-symptomatic. Our research is directed there. And it's not really so clean up and down, this much angle equals that much memory impairment. What actually happens is something that looks more like this little slanted relationship where there are some people who develop symptoms of MCI at much earlier stages of disease. And that turns out to be because they have something else matter in the brain, maybe some small blood vessel vascular brain injury, or maybe another medical problem that leaves them at risk, like bad sleep apnea or something like that. And then there are other people that, despite having a lot of Alzheimer's disease, and I'll tell you how we measure that, despite having a lot of Alzheimer's disease, they don't have much impairment. Maybe they have only mild cognitive impairment when they should, by rights, have dementia. We call those people resilient, or to have what we call cognitive reserve. And that turns out to be not just a function of no other comorbidity, it also turns out to be a function of how you developed your brain in the first place, how much education you had, how demanding your job was cognitively, how many hours a week you spend doing cognitively challenging activity currently, how much physical activity you get, how much social connectedness you have, all factors into how well you withstand and function in the spite of having some Alzheimer biology going on. And that is really cool. It's modifiable. And this slide's a little complicated, but let me just say that in a study that the Mayo Clinic did, don't pay attention to the slide, it's too complicated. These factors, these 4 factors I'm going to mention, how much education you had, how challenging your job was or is, and your midlife and late life cognitive habits. Collectively, those factors make up to 8 or 10 years difference when your tipping point will be, how much Alzheimer's disease it takes for you to tip into something that we would measure as impaired. Okay, so it's a lot of difference. It's a really important clue to the biology of the disease. It's a really important clue to how we tell people to live if they have memory loss and how to prevent it. Okay, so that's resilience. So there's this long pre-symptomatic window that I mentioned, and your cognitive lifestyle over the decades makes a difference in how much resilience you have. And you can postpone your tipping point by years. And it turns out, like in that Mayo Clinic study, for people who didn't have the opportunity for a lot of education or a cognitively challenging job, they were able to make up ground later by their cognitive habits. So it's not written in stone. You can still modify things for the good through the lifespan, as far as we can tell. All right. And we talked about all of that. Okay, so now let me shift gears now into like the clinical, how we approach treatment for this. So the term that I want to get across is what we call strength-based reframing of Alzheimer's disease. And if you followed me so far, the brain isn't affected evenly. Some places in the brain are affected early and some are affected mildly or maybe later or maybe never. And the spared parts are correlated with the strengths that you retain. I gave the example a little while ago of procedural learning, right? Procedural learning is spared in Alzheimer's disease, and someone with early Alzheimer's disease can learn a new habit or skill just as well as anybody else, okay? So we have treatment programs kind of built around these ideas. And our goals, are to help people stay independent longer, stay at home longer. And our goals are also to get across that not all Alzheimer's disease goes the way of the worst case scenario that you probably imagine when you hear the word Alzheimer's. Okay? In fact, when you intervene early, that scenario doesn't happen as often. So we're trying to counter stigma, get people interested in getting an early and prompt diagnosis and working on this when it is optimal to do that. So that's what we call strength-based reframing of Alzheimer's disease. It's not all about what's lost. It's also about what's spared and what that helps us to do. Okay, so there's the lady doing Wii bowling. And I mentioned we have this strength-based approach in our treatment program. We have a program we call ADAPT. And ADAPT is a 2-week boot camp for people with mild cognitive impairment. You come to ADAPT with your partner, could be your spouse, could be your adult child, could just be a good friend. And we put you through 24 or 27 hours of stuff over a 2-week period, okay? And lay the foundation you need to build those habits that can prolong your functional independence. Some of the things we work on, just a couple of examples. One of the things we work on is a memory notebook training thing. It sounds very simple. You have a calendar or a notebook that's in your pocket and you always write stuff down. And it's always in the same place. Always. Did I say always? Yeah. And what happens is people build that habit and when they need that information, it turns out it's always there because they've developed the habit and it really does work. And there are other parts of the treatment that are based on that same principle. And we've learned there's a lot of things that are pretty spared. So your motor and sensory abilities, we talked about that. Learning new skills and habits, we talked about that. Accessing memory from sensation as opposed to just spontaneous retrieval of that information. So the prompting of that information by the context, the environment you're in, that's spared. And then one really interesting thing is the creativity or creative impulse is spared. There's something really deeply intrinsically human about creativity. And arts-based kind of programs turn out to be super therapeutic for people and easy for people to do. And learning in a social context is also spared. Okay, and then the last thing I want to talk about is, now this is more the medical aspect of the treatment, but how we now measure and detect Alzheimer's disease in living people, because many of us heard you can't make that diagnosis without an autopsy in the past, remember? Myth, not true. And I'll tell you why. If you come to our clinic, we can determine this, even when things are very mild, and it does really help us orient how to best treat. So to back up to plaques and tangles, you should be familiar with this picture by now. There's kind of a couple ways to think about them, but they're not just the hallmarks of Alzheimer's disease, not just that which defines Alzheimer's disease, but the proteins that compose those plaques and tangles are proteins we can measure in the laboratory. Okay? And those measurements are what we call biomarkers. So we can measure in spinal fluid, we can measure in blood plasma, and we can measure on brain scans exactly how much amyloid or tau protein is around. Okay? So these these biomarkers have revolutionized how we approach things. And we use this framework we call ATN. ATN means amyloid, tau, and neurodegeneration. But there are measurements we can take to pertain to how much amyloid is around, how much tau is around, for example. And everybody can be put on this, somewhere on this framework of whether you have A, whether you have T, or whether you have N, okay? And if you have A, amyloid, too much amyloid, then you're on this Alzheimer's disease continuum. You might be in the preclinical or the MCI or the dementia, but you're somewhere on there. And that's defined entirely by what we measure in the biology, entirely by the test for how much amyloid is present. And to the extent you also have the positive tau marker, there's actually degeneration happening. There's tissue loss happening. So let me just show you an example. This on the bottom here, this is somebody's MRI scan. And on the top is what we call the amyloid PET scan. So this is a scan that's there to measure how much amyloid accumulation is in the brain. And this is a normal scan. And the way, just think about it as a photographic negative of the bottom one, okay? The white matter looks black on the amyloid scan, and the gray matter looks white on the amyloid scan. People kind of see that? All right, here's an abnormal scan, and you can see that it's not a simple negative anymore. You can't see the structure of the white matter anymore in this amyloid scan because the gray matter is full of amyloid. Okay, and so it almost has this kind of ground glass appearance to it. And that's a positive scan that indicates you have at least moderately dense amyloid plaques in the brain. This amyloid scan is already maximally abnormal when people come in and get a diagnosis of mild cognitive impairment. It's already been accumulating for 10 or 15 years in the brain. It's hardly ever a close call. You have amnestic mild cognitive impairment, we get the amyloid scan, it's either normal, good news, or it's not normal at all, and hardly ever anywhere in between. And it's really rapidly becoming the gold standard for diagnosis. We can also do a tau PET scan, which measures how many neurofibrillary tangles there are, and that is something that doesn't have a clinical role yet. It's a research role, but it does follow very closely how much and how extensive the brain degeneration is. So in research, we use it to track the disease over time, but the amyloid scan we use to certify diagnosis. And like I said, I kind of think of amyloid as the insult and tau as the impact of the disease. And you know, if you follow this is called a spaghetti plot. You want to know why? You know, people vary a lot in terms of how much amyloid they have in the brain, but someone figured out if you just align them all on like one timeline, you can show that this is a kind of a smooth, exponentially increasing burden of amyloid that happens on a little different clock for each person, like different starting time. But if you align how far along you are in the process, you get this nice height trajectory of accumulation of amyloid that happens over 10, 15, 20 years. And if you look at that blue line I showed you, that trajectory I just showed you is this blue line. It's the rate of a positive amyloid scan in us, in general population. And the red line is the rate of Alzheimer's disease dementia in the general population. You see they're very parallel to each other. And there's 15 years lag. Okay. So if you follow, that means that your future cognitive course is predicted by your amyloid course. And if you look at age 70 here, about 25% of people at age 70 have a positive amyloid scan. So it gives you some sense of how many people in the population are going to be at risk for trouble in ensuing decade or so. And so I think of it this way. Most of us are thinking of Alzheimer's disease in terms of the dementia, but the mild cognitive impairment and the asymptomatic stages of it are this big iceberg below the water. It's the actual numbers of people affected by Alzheimer's disease. And I'm going to just say that without amyloid around, that tau, the progression of the nerve fibrillary tangles doesn't happen. It's really important that the amyloid is around, and the tau accumulation is in some sense downstream of the amyloid problem. This is just one slide. You don't need to understand it, except it gives me a chance to tell you that all of what I just said about amyloid doesn't necessarily require a PET scan or a spinal fluid tap. We can now measure it in the blood. This is coming soon to a clinic near you. We use it in research routinely. What's that? We use it in the research routinely. In the clinic, it's just a matter of when your insurance starts to pay for it, because we can already send out for it. So this is going to turn into a situation where we can determine from a blood test whether you have preclinical or mild clinical Alzheimer's disease or not. And then I have one slide on this, apolipoprotein E. This is that genetic marker I told you about a little while ago. We can measure this in the blood. This is the cholesterol carrying protein that everybody has. And everybody has one of three flavors of this ApoE. One is called E2, and one is called E3, and one is called E4. And it's that E4 that about 15% of us carry that is a risk factor for Alzheimer's disease. It's a strong genetic risk factor. It does not mean you are going to develop Alzheimer's disease. It means you're more at risk. Okay, that's on the test. But the reason I'm telling you about it is it also not only governs your risk of Alzheimer's disease, it also governs your risk of complications of the treatment that we're offering. So something to think about. So biomarkers, Alzheimer's disease is latent for 15 years. And the only practical way to separate normal aging from pathological aging or preclinical Alzheimer's disease is with a biomarker. It's the only way to separate them. So if you think to a future where we can intervene in that pre-symptomatic window, that means that you're going to need to have this kind of blood test done in your primary care situation as a screening test. That's what the future is. Right now, we don't have the treatment available for the preclinical situation. But it does offer this opportunity to delay or even prevent dementia, and that's what we're working on. And like I say, these plasma read blood markers are coming soon to clinical work. So amyloid protein is the insult. We don't know that we don't really know that much about it. It's funny, we name it the amyloid protein because of the bad stuff it does. It forms amyloid and gums up in the brain, but we don't really know what its normal function in the brain is. It's made every time your brain synapses fire, they make amyloid. It's doing something important, but we don't know. But if you make too much of it, it's trouble. The gene for amyloid is on the 21st chromosome. And the reason that that's important is how many people know Down syndrome is 3 copies of the 21st chromosome, and everybody with Down syndrome gets Alzheimer's disease. They all get premature Alzheimer's disease because they make 50% too much amyloid protein. And there are these rare families in the world where the only genetic trouble they have is a duplication of the amyloid gene. So they have an extra copy of that amyloid gene. And all those families get early onset Alzheimer's disease. So amyloid protein is enough by itself to cause Alzheimer's disease. None of us currently think it causes all Alzheimer's disease or it's the only thing, but certainly it's enough to do it. And we've been interested in how we can remove that insult from the brain as a therapy, right? So that brings me to the kind of state of the art, which is what we're calling amyloid clearing immunotherapy. This medicine has been in the news for the last year or two. You may have heard of lecanemab, which is the one which is currently FDA approved and Medicare covered that we're starting to use. There's another one on the way that's similar to Leqembi, and this is an antibody that we infuse intravenously in the arm every 2 weeks for a while to cause cleanup of the amyloid protein. And what you see on the right here, this is kind of over time as you go down the slide. If you're treated with the amyloid clearing antibody, you basically get a negative amyloid scan by the time you're done. It really does remove the amyloid burden from the brain. And people worried for a while that, so what? It removed the amyloid protein, but maybe that didn't make people's lives or memory better. But didn't skip to that. In the trial that was published in the New England Journal, over that 18-month period, the two curves did separate. The placebo group declined a lot more than the lecanemab treatment group. And one way to think about that is if you look at the blue line, how much they had declined by 12 months. It took the lecanemab group 17 months to get to that same level. So slowed it down by 5 months out of that 18 months, 30%-ish. Okay? Not a cure, but the first time we've ever been able to modify the biology of Alzheimer's disease and show a positive outcome from it. And the other thing that happened is the markers of the tau, the thing that's in the nerve fibrillary tangle, also got better. So the downstream consequences of the amyloid insult were also better as a result of treatment with this. So that's why, as a field, we're kind of excited to have something now to offer people. And it's turns out it's not like free of trouble. So that's going to cause me to back up. Because amyloid accumulates not only as plaques, these plaques in the brain substance, but also accumulates in the walls of the small blood vessels in the brain. And the lecanemab is going to go and fish it out of the vessel walls as well as the brain substance. And when it does that, that vessel can get a little bit leaky. Okay. And then you see some fluid extravasation into the brain substance. And even some small scale hemorrhaging can happen. So those complications are collectively called amyloid-related imaging abnormalities, or ARIA. I hate the acronym, but that's the way it is. And it shows up on an MRI scan. This almost always is not symptomatic to the person who's getting the medicine. It's almost always tracked down on an MRI scan that we do periodically for surveillance, although it can cause symptoms. But this is what limits your dose of lecanemab, and this is what causes us to kind of follow and keep kind of a tight rein on you for a year and a half while you're in this therapy. Okay, so that's, and then the rates of ARIA are somewhere around 15 to 20% in people who take this medicine. And then that ApoE, that genetic marker I talked about, if you have E4, your rate is about 11% of having ARIA. If you have both copies of E4, that is from your mom and from your dad, E4, and that's not many of us, but maybe about 10 or 15% of people with Alzheimer's disease, then your rate of ARIA is about 33%. So it's higher. So we have to take that into account when we're prescribing. Okay. So just summing up then. So if you have mild, you might be eligible for lecanemab if you have MCI or what we call very mild dementia. To me, that means you have minimal dependency and you're really your own decision maker. And you have a positive amyloid marker either in the spinal fluid or on the PET scan, or maybe next year on the blood test. Okay. And you can get regularly to our infusion center, and there's no reason you can't have an MRI scan because we need to do that to monitor you, and you're not on a blood thinner so that you would be at risk for bleeding. And if we have a good discussion with our experts and with you, then you could be a good candidate for lecanemab. And about 15% of our clientele at Memory Brain Wellness Center are candidates. And so I think we're up to our 25th patient now in the infusion sequence. And it's a big journey. It's 18 months of getting an infusion every 2 weeks, so it's a commitment. If you live in Yakima, it might be hard to do. Come into Harborview every 2 weeks. But on the other hand, it's nice to be able to offer this kind of treatment. And it's a case-by-case decision. I just told you, we select people based on their cognitive stage and their MRI scans and their biomarkers and, individual health profiles. It's also important what the patient thinks. Like, is 30% slowing enough benefit to go through this much trouble? How well is Medicare and your secondary insurance going to cover this? And how easy or hard is it for you to get to our infusion center? So reasonable people make different decisions, but we have a well-defined program on this now. So like when I started treating people with Alzheimer's disease in about 1990 or so, this is when we encountered people, at the stage of dementia. I sometimes facetiously say, yeah, they got to the 10-yard line before anybody tackled them. Okay. They're already at the 10, you're probably going to score, right? And we had, there's some symptomatic medicines, some medicines to help the brain function better, but nothing that would interrupt the natural course of Alzheimer's disease. In 2020, we intervened in mild cognitive impairment. I would say in 2024, we intervene here, one step over the line from normal cognition to mild cognitive impairment, because the ideal candidate for lecanemab is somebody who's objectively impaired, but very early in the course. That's when we think we can make the most difference. And so our treatment programming is really meant to intervene at the stage of mild cognitive impairment, doing all sorts of things to minimize comorbidity, like whatever we can do to maximize your vascular health, your mental health, your resilience, as I talked about, building resilience, and then leveraging the routine strengths you have and to compensate for the problems as they do develop. I'll say a word about dementia-friendly community, but basically, if you think about strength-based reframing, people living with memory loss and dementia, they have a potential. They have a lot of spared strengths. They should be able to live to that potential in the community, and that's part of the overall program of reducing stigma and improving quality of life for people with memory loss. And then finally, we now have this disease-modifying medication, and this is really revolutionizing how people think about Alzheimer's disease, because you now have a solid reason to seek an early diagnosis. We can't give this to you if you have more than mild impairment. And it's also accelerating the availability of these biomarker tests, especially the blood tests. So it's really changing medicine for memory loss pretty profoundly. So, when I started working on this, it was all a narrative of loss. People think Alzheimer's disease, they think inseparably from dementia. But I told you, Alzheimer's disease doesn't necessarily mean dementia, right? You could have preclinical disease or mild cognitive impairment, or just subjective memory loss, or even normal cognition. And you can build cognitive reserve, and you can engage the strengths, and you can live well. So it's a much wider frame to think about memory loss and dementia. And one of the things we've been doing is really trying to promote these three big ideas: building resilience, strength-based reframing, and dementia-friendly community. And I'll just leave you with, on the dementia-friendly community side, we have a really innovative program in partnership with the Frye Art Museum. People know the Free Art Museum on First Hill. We lease some of their space on their campus there and have a positively framed non-clinical community center for people with memory loss and dementia, where we work side by side with people like the Alzheimer's Association and ElderWise and Full Life Care and a bunch of other programs It's a really nice, inviting 1970s building with an art gallery and a library and a really beautiful memory garden in the back and a lot of online resources as well. So if you have an interest, drop by someday, check us out. And with that, I'm going to stop. Welcome any questions, and I'll leave up our URLs in case you want to check out our website. Okay, thank you.